Today, I'm very honored to introduce Dr. Kat Toups. Kat Toups, MD, is a functional medicine psychiatrist and researcher using multimodal approaches to treat cognitive impairment and dementia, combining the best of precision, functional, and regenerative medicine. She is a distinguished fellow of the American Psychiatric Association and certified by the Institute of Functional Medicine. Kat has been practicing psychiatry for 35 years and functional medicine psychiatry for the past 14 years, as she's been a featured speaker at national and international medical conferences on dementia and functional medicine psychiatry topics, as well as a frequent guest on podcasts and summits. As a prolific researcher, she's been the principal investigator on over 100 clinical trials, including her collaboration with Dr. Dale Bredesen on the pioneering work using functional and precision medicine to reverse cognitive decline and dementia. In their first groundbreaking trial, 84% of the study patients had improvement, including even the MRI head scans. Their first paper, Precision Medicine Approach to Alzheimer's Disease Successful Pilot Project, was published in the prestigious Journal of Alzheimer's Disease in July 2022 and already has 71 citations on Google Scholar over the past 2 years. Two additional papers have also been published from the study. They're now hard at work on a larger randomized precision medicine clinical trial at 6 sites to replicate and expand on the findings from the first study, and there's some exciting data already coming out as the study is more than 75% complete. Kat is also the author of an upcoming book, Dementia Demystified. She's a hero to me, my dad, and family, and I'm very grateful to have her on with us today. So, Dr. Toups, I really appreciate you coming on for our listeners. Thank you. How are you?
I'm great. Thank you. And thank you for having me. And thank you, Eddie, for all the work you're doing to help share with people the news that not not everybody realizes yet, that, if we can catch, cognitive decline and dementia before it's too far along, we can really get people well. So I'm happy to talk about that, my favorite subject.
Yeah, yeah. Yeah, no, absolutely. My favorite subject as well. And thank you for everything that you're doing because it really is life-saving work. So we got to start off, and you got to tell me, how did you start working in functional medicine?
Well, that was my own health. I think many people in traditional medicine come to functional medicine because either they're sick or their family members sick, and they come up against the limitations that sometimes traditional medicine has to offer. Of course, many things it's wonderful for, but cognitive decline has not been a good area. As you mentioned, I've been a researcher on many pharmaceutical trials. I did 20 long-term trials with Alzheimer's and many of the drugs that are out there. And, I think most of us are familiar with the dismal results of that. So I was in the midst of running a clinical trials research center, doing quite a few trials. And I gradually started to realize that I was becoming as cognitively impaired as my patients in my Alzheimer trials. This was 15 years ago, almost 16 years ago now, and I was 50 years old. And I would test my patients on the many mental status exam. This was before we used the MOCA exams that we use now for earlier dementia and MCI. But you would ask them to recall 3 words on that test instead of 5 words like we do now on the MOCA. And I had 2 different sets of 3 words, and I had used those for more than 20 years. So I knew those words like the back of my hand, and suddenly I couldn't remember them. And I would go to ask my patient the 3 words, and I realized I had forgotten which words I asked them. So I was writing it down to quiz them. That was my real moment of truth. Like, you're getting to be as bad as these patients in your trials. So I was very much struggling with quite a few things, and so at that point I had to move my trials over to another center. And I thought I was just going to take a couple months off of work and get well, but it was rather a 3-year journey of learning about functional medicine and trying to learn functional medicine while my brain was having trouble. I always said I had a sieve for a brain, like everything went straight through it. But I also couldn't do things I knew how to do before. I was really struggling using a computer. I would ask my husband over and over to show me how to do things on the computer that I had forgotten. And he would get irritated because he would say, well, I just showed you how to do that. And I was asking him repeatedly because I wasn't even remembering that I had asked him. I was having trouble driving a car. I couldn't back up or parallel park. I was having trouble dialing phone numbers. I couldn't hold a phone number in my head, and I would get confused, and it would take multiple tries. So my brain was completely inflamed and going down. And so I, certainly knew enough to know that nobody, for starters, people at that point, even seeing somebody at age 50 with cognitive decline was an anomaly. And, I had treated some people in their 50s with dementia, and it seems to go much more quickly. It's, more obviously acute medical issues at that point than people tend to think of with a later onset dementia. But the good news is I worked through every single module that I learned in my training of functional medicine and applied every single thing to myself, like all of my patients. It's never just one thing that's causing the cognitive decline. It's multiple things that come together and create the perfect storm. So I had to uncover all of my underlying factors, and gradually I got better. And I think for me, the moment of truth was one day I was able to dial a phone number. I could hold those 7 digits in my head and dial the phone number. And that's when I realized, oh, my brain has come back online. It's back, kind of thing. So that's a kind of a long-winded story of how I came to functional medicine. And of course, once I learned it, I realized this is what all of my patients need. Not only for cognitive decline, but I'm a psychiatrist, so working with psychiatric disorders, I had done so many pharmaceutical trials with so many medications, and every new medication, new mechanism of action, I thought, okay, here's a new mechanism of action for depression. This is going to help my patients. And, medications can help some symptoms, but what they weren't helping was for people to get well. And so, once I learned functional medicine and the root cause resolution of things, it was just the light bulb went off that this is what patients need. So that is how I immediately shifted to functional medicine and could never go back.
Yeah. Beautiful. Beautiful. And then how did you get introduced to Dr. Dale Bredesen's work?
Let's see. I encountered Dr. Bredesen pretty early on. I think he was offering his first group training session at the Buck Center of Aging, big, prestigious research center that he was the first president of. And he had been introduced to functional medicine by his wife, who's also a physician, and had learned some functional medicine. So I went to the first training that he did. And of course, we realized, instantly that what he was, learning and espousing for people to get better was exactly what I had done and what I was doing with my patients. So somehow we connected at that first training and have kind of been on the journey ever since. And I think, as you mentioned, I work with him on the clinical trials, and I've been the principal investigator on both of the trials, which means I kind of, have to have more direction and oversight of everything. But and they're quite involved clinical trials, and definitely a labor of love. But yeah, so we've, and I guess, we kind of, you alluded to our first trial where that was our pilot trial. We had 25 patients, and 84% of our patients had improvement. And we were shocked to find even their head scans were getting better. We didn't know that till long after the trial was done. We work with a wonderful neuroradiology professor, Dr. Cyrus Raji, and then he was analyzing all the volumetrics and looking at the various factors. And we were shocked to find out that their head scans were well, even with normal aging, you expect decline in certain things. In the head scan, the brain volume declines over time. The hippocampus, which is the memory center, declines over time. Even with normal aging, it just goes much faster with MCI or Alzheimer's. But in our patient, and then the gray matter declines. Well, in our study patients, the gray matter actually improved.
Wow.
instead of declining. So it was far better. It was statistically better than normal controls with no cognitive decline of the same age. And then the hippocampal volumes did decline slightly, but again, statistically better than normal controls and far, far better than MCI or Alzheimer's. And there was no loss overall of the brain volume that was expected. So,
Wow.
it was only a 9-month trial. That was shocking. We didn't expect to see that at all. And, it will be interesting to see what happens with our current trial. So our current trial is a bigger trial.
Yeah.
We're doing it at 6 different locations around the country. We've enrolled 72 patients in that trial, and it's called a randomized clinical trial. So the patients are randomized either to get the active precision medicine, functional medicine treatment, or to get standard neurology treatment, which sadly is kind of not much of anything.
Yeah.
If you go to the neurologist early on having cognitive symptoms, they will test you. They might look at a couple of labs like your B12 level, maybe your vitamin D. They'll look for syphilis, but they're missing many other infections, which we can talk about and should talk
Sure.
about.
Sure.
But they pretty much say, take care of yourself, eat right, sleep right,
Yeah.
back in a year and we'll see if you're worse, right?
Right.
So we
Right.
were trying to replicate that. It wasn't easy to replicate because things are changing and people are learning more and more about all the things they can do to help their cognitive decline. But we asked our patients to try not to change anything. Don't change your exercise. Don't change your vitamins and supplements. If you're taking things, you can keep taking them. Whatever your exercise is, great, but don't suddenly do something new. And so patients were randomized, and 1/3 of them were randomized into that group, which we call delayed treatment, because we had funding so that when they completed the 9-month trial, we were able to offer them 6 months of active treatment with all of the coaching and the labs and the supplements and everything else that we offer the active treatment. So it was kind of still a win-win for them. But 2/3 of the patients got the precision medicine, individualized treatment, and we are just over 80% complete at this point. And right now, doing this interview, we are in mid-June, so we're expected to finish the trial in early November of 2025.
Nice.
We've been looking at the data now, and I did present the interim data 2 weeks ago at the Institute for Functional Medicine's annual international conference. And, I do have, I've worked with a statistician. I have graphs on the different cognitive markers, and we call them Group A and Group B. So Group A is active treatment, Group B is the delayed treatment. And we're seeing some exciting results and differences between the two groups. So we have little ways to go. So
Amazing.
I can't tell you, the final results, but we're definitely on track. That I think this is, going to further solidify the validity of the kind of approach that we're using.
Yes. Yes. Yeah, no, that's excellent. I mean, such a great study, the 2022 clinical trial, just building off of, I just remember reading the first 2014 paper on that first, 10-person study. And then every time there's been a new study, new paper, it's just been so tremendously inspiring to see the kind of results that you guys are getting with this multimodal approach. And yeah, I mean, look, 2018, uh, first time I took my dad to the neurologist. All they tested was B12, TSH, basic metabolic panel, and that was it. So big contrast to what you guys test, and we'll get into that. But you know, why have past treatment approaches for Alzheimer's failed for so long?
Well, I mean, a couple of reasons. I think, the biggest thing is they're looking for one pill
Yeah.
to turn off a disease process that is occurring from different reasons in different people.
Yep.
So, there's just not, it's just like trying to use a sledgehammer for hitting a little tiny target somewhere. Like it's just not going to work. And, you can give things that might improve the cognitive functioning temporarily, but you're having a neurodegeneration is it's an ongoing neuroinflammatory process, and you're having destruction. And the more neurons you destroy, each of them projects to lots of other neurons, and so eventually your brain gets eaten up, right? If you don't do something. So just trying to find one treatment. I mean, that already is the big obvious elephant in the room. It's just not going to work.
Yeah.
And we've been stuck in the amyloid hypothesis. And, so the amyloid hypothesis is, well, we know the hallmarks of Alzheimer's disease, which is the most common type of dementia, is, you get deposit of amyloid, which is a gooey, sticky substance that's secreted around the neurons when there's a hostile provocation, something that's provoking it, something that wants to hurt that neuron, causing inflammation. And that can be an infection, can be a toxin, chemicals, mycotoxins. It can be degenerating because the glucose levels are too high, and that's creating neuroinflammation, and the lipids are out of whack. So many factors. But when there's an insult in the brain, then the amyloid gets secreted to try to protect the neuron. And if it's a short-term insult, like a temporary virus, like COVID has really shown the world what a virus can do to the brain, because one of the treatment targets that we work with is identifying infections that are affecting the brain. But now we see even young people having cognitive issues after having COVID, right? Not everybody, but for some people that really seems to affect their brain. And so if you have a short-term thing and your body can clear it, the immune system can clear it, or you can clear out the toxins or the exposure, then okay, a little amyloid is okay. But if it's being chronically secreted and deposited, then eventually it just gums up everything. It's a sticky, gooey substance. So the idea has been, well, amyloid is one of the hallmarks of Alzheimer's, so let's get rid of the amyloid. So we have drugs that can get rid of the amyloid. And I did one of those studies a number of years ago when I was still doing clinical trials, which I stopped doing in 2009 when I was too impaired to work any longer. So, in the early 2000s, I remember one of my drug studies, and we could show on the PET scans that the amyloid decreased, but people didn't get any better.
Right.
Because that is it's an effect, but it's not the cause.
Yeah.
So, our job really is to look further upstream of, well, what caused that amyloid to be secreted? Let's fix that. And then maybe once we fix these factors, clearing out the amyloid can be useful. But just clearing that out without fixing things, like say you have lung cancer from smoking, and okay, you can maybe get a surgery or radiation to clear the cancer, but you're still smoking. You're still creating the conditions that led to that cancer, right? So that's really why this isn't going to work, just having an amyloid drug. And of course, the newer ones are more specific, they're more potent, they're wiping out the amyloid, but as a sequelae of that, people are having, I think, 24%, up to 24% of people can have brain bleeds, which can be fatal.
Yeah.
Right. I mean, they've had patients die in every one of the trials and the subsequent releases of those medications. So, you're taking a toxic drug that can cause more brain damage, can cause death, to get 6 months of improvement, but you're still going to keep declining. So, it's sad, but there's still so many amyloid drugs in the pipeline.
Oh yeah.
That people, it's the way that in general pharmaceutical industries work, and for many things it works. You have this infection, if you can find the right antibiotic, it's going to take care of it, right? So many things, a pharmacological approach is useful, but in this instance, it's not useful.
Yeah, makes total sense. Yeah, that was one of the biggest breakthroughs in reading The End of Alzheimer's so many years back, was just that distinction that Dr. Bredesen had made there, and others have made it, Dr. Rudy Tanzi, or, all these years. It seems like all this focus and money and concentration has been on removing what was perceived to be the arsonist, when in reality it was the firefighter. And the arsonist was still running around and was not identified because the testing wasn't in place to figure that out.
Right.
So that's huge. So, you alluded to some of these triggers, these provocations that are the ones that stimulate the amyloid growth. What are some of the main environmental and lifestyle factors that have been contributing to the higher rates of Alzheimer's recently?
Oh gosh, well, the I think for starters, our world has just become increasingly toxic. I think anybody who lives on planet Earth has got to be aware of what's happening with increased levels of chemicals and toxins. I mean, we can start and look back on what happened to our diet since the 60s when processed foods came on the market. But processed foods also means preservatives and additives and mass production of food needing more pesticides and herbicides and so it's just there's population pressures and what's happened in general life to increase our toxic burden. So I think that then segues into the more toxic we become, the more it infects our immune system.
Yep.
And we're just having an explosion of immune disorders. And it's things that were when I started my medical training in the 80s. There were some discrete immune disorders, but not this whole spectrum of so much autoimmunity that we're seeing now. So
Yeah.
I think that's kind of maybe a big thing is the toxins and the dietary changes and the lifestyle changes and now that we have, I can't tell you the exact percentage, I don't treat children, but the amount of children with diabetes and autoimmunity is just through the roof right now. So I think it really kind of comes back to we need to take better care of our earth,
Yeah.
right? Because the toxins are a huge factor. I think it was interesting, like with things that we learned from the 9/11 with Ground Zero in New York and the Twin Towers, and all the firefighters that were there helping and the EMTs. So many of them started developing dementia quite early, and also all kinds of cancers and immune problems from all of those toxins that they breathed in.
Yeah. Yeah.
With the destruction there. So yeah, I think that's again one of our upstream factors
Yeah.
that is a bigger problem. We can try to control what we eat, trying to eat organic, trying to eat free range beef, trying to eliminate the chemicals that we use in our households and put on our hair and skin. But I mean, they're still ubiquitous, right? Babies are born with a couple hundred chemicals already in their body from their mother.
Yeah.
So it's I think that's to me, I think that's one of the big reasons.
Yeah. Yeah. No, I'm with you. I mean, some of those graphs that show that it's been every year without fail that we have more gallons of pesticides and herbicides that are being sprayed on everything, commercially, residentially. Um, and
And
yeah,
I mean, it's just coming out like a lot of big news that Parkinson's being linked to golf courses, living near a golf
yes,
course gets on the water supply, you breathe it in. Well, this is something we've known in functional medicine for a long, long time. It's,
yeah,
part of my questionnaires where I go through all the different risk factors for things that, can increase your dementia risk.
yeah,
And, but, somehow it's suddenly news, but I'm glad, even though some
yeah,
of us know about it, but the connection between those chemicals and neurodegenerative
yeah,
disorders and I mean they've made the linkage to Parkinson's, but
yeah.
it can be a factor with all kinds of neurodegenerative disorders.
Oh, absolutely. Yeah, especially glyphosate. Yeah, it's amazing what we're surrounded by, but yeah, you're right. Well, some of these factors, I mean, you address all of them in the trial. Uh, as we jump into that 22 trial, um, what was the dietary intervention that you guys used in the for the participants?
Yeah, that's a really good question because we wanted to standardize things for the purposes of the trial, and I should start by saying there's no one size fits all diet. Diets have to be individualized. We all have different needs and what we can do, but for the purposes of the trial, we did try to standardize it. Of course, if there were health challenges or reasons that the person couldn't stay on our diet, then we worked with that. But we did ask all our patients to eat a ketogenic diet. Dr. Bredesen has talked about this extensively of the difficulties that with aging, normally we can use either glucose or fat as fuel for our body and our brain. But with aging, we get less flexible at being able to utilize the glucose. And of course, we're seeing, huge amounts of insulin resistance and diabetes that are driving that. And so if you switch people into burning fat for fuel instead of glucose, that increases the availability of energy for the body and the brain. And it can work quite beautifully for some, not all people with cognitive decline. So sometimes people's brains just light up, like they just feel so much more energy. Their brain clarity is better on ketosis, and other people don't notice it much. But for the purposes of the study, we did ask everyone to be in ketosis. We asked them to try as much as possible to eat a whole foods diet and avoid processed foods with all the additives, chemicals, food dyes, etc. We asked them to try to eat free-range beef and chicken and wild-caught fish, again, for all the issues that come. I mean, the feedlot beef is something that's worth mentioning because it's tough. Free-range food is more expensive, right? But being sick is way more expensive. And the feedlot beef, the cows are kept in non-humane conditions. They're crowded. They give them antibiotics. They're highly stressed because they're in these crowded conditions and not in a natural environment. And just they have cortisol like we do, the stress hormone, and that causes inflammation when it's raised, right? So the feedlot beef tend to be highly inflamed. And the way you can see this is just looking at the omega-3 and omega-6 fatty acid levels. And, a lot of people take fish oil, omega-3s, because they're very anti-inflammatory and they're good for our lipids and they're good for our heart and they're good for our brain and they're good for our skin. And, they're wonderful supplements. But when you look at free-range beef, they are very high in omega-3s and they're low in omega-6s, which are a pro-inflammatory fatty acid. Now, you need some. There's a balance with those too, but in general, we want to have that high omega-3, low omega-6. Well, the feedlot beef is the other way around. It's very high omega-6 levels, low omega-3s. So it's just it's inflammatory. Also, they want the cows to be fat because they sell more beef, right? That, kind of makes sense. And so they feed them a bunch of grains and wheat to make them fat. And too much grains and wheat make us fat, eating all those carbs that are, you can't burn off the excess carbs for fuel and you turn it to fat. So they want to make the cows fat. But we know that fat itself secretes inflammatory cytokines.
Yeah.
So it's a difficult thing when people are overweight and they're trying to diet and exercise, but because they're inflamed just by nature of the fat, sometimes the diet and the exercise isn't as successful. You've got to help them with the inflammation as well. So anyway, the animals, what we're putting into our body, that's a huge thing. So we tried to work with our patients. Each patient had a nutritionist to help them with all the changes and the dietary changes. We asked them in the first study to be at least in mild ketosis.
Yep.
We wanted to have the levels, at that study, I believe we said 0.8 to, they could, go higher. But what we discovered from that trial is that the further people went into ketosis, so the higher their levels, they would get more better, So, it was definitely a learning curve for us and certainly for me to see that with my patients. So in our current clinical trial, we're asking people to have their ketone levels between 1 and 4. Nice. I don't really like my patients to go much over 3. I mean, I don't want them to get too high, but it's also, our own learning curves of how better to support people. I have to say it does really help in the beginning to work with a nutritionist to help make this switch properly. And it can be done quite quickly. The nutritionist that I work with in this trial, and she also works with Dr. Anne Hathaway's site. We're in the same geographic area. Yeah. Her philosophy is put people into ketosis very quickly, restrict things as needed, yeah, and then start adding them back in. So once you get into a good level of ketosis, she has phase 1, 2, and 3. So when they're in a good level of ketosis, then she adds some more things in phase 2, lets them, eat a little more carby vegetables and, things like that. And then when that's solid, she goes to another level where she lets them expand things as they get better at maintaining their ketone levels. And I think psychologically, that's a kind of a nice approach. It's kind of hard where you say, okay, we'll take away this. Okay, you don't have enough. Let's take away some more. And let's take away some more. That gets discouraging. Yeah. So I do rather like this approach that she has of help people, get straight away into it and then expand the diet. And, it's harder for some people than others to do ketosis based on their background blood sugar levels. Yeah. So somebody who has a low hemoglobin A1C and generally, good blood sugar, they will go, you can get into ketosis in 2 days, 3 days, clearly by 3 days. Yeah. But somebody who has a higher blood sugar, then you're going to have to deprive them more and more of the carbs before they'll go into a solid ketosis level. Right. But, one thing too is, I have in my current cohort, I would say half my patients are in their 70s. So, they're not young people, but you should see how much younger they turn by the end of the study. Like I always take pictures of them. I have pictures at the beginning, and in the end, I'm like, oh my God, I got to get a picture of you. You look so much younger. And of course, they feel younger. But, it becomes harder the older you are to be flexible and, change something radically like your diet. But I can tell you that they all did it. And we asked them to cut out gluten and dairy as well, because both of those are so inflammatory. So just cutting out gluten and dairy is a huge shift for people. And then, working with how can you be in ketosis? How can you still go to people's house for dinner or restaurants? And, that's, a little bit of a journey, but it can be done, and all our patients did it. And I've been conducting some little video testimonials with some of my patients for the study. And also we've been working with a videographer to document all of this. And so I've been in on those interviews, and my patients over and over say, I wouldn't have thought it, but I love being in ketosis because I feel so great. My energy is really great. I don't feel hungry. Yep. Don't have any cravings for sugar. Once you get past the withdrawal of cutting out the sugar and carbs, and there is definitely withdrawal for some people to do that. But I just heard over and over people saying for the videos how well they felt in ketosis, and they just felt in so much more control of their eating, their weight, their energy. So a lot of them have chosen to stay in ketosis. Some people, we decide modified keto, have, 1 or 2 days a week, or going out special occasions, maybe that you would, change the diet. So again, it's not a one size fits all. There's one thing I want to say about ketosis and lipids, though. Classically, people say, okay, you shouldn't do a ketogenic diet if you have high lipids. Well, so many people have high lipids, but what I have seen in my patients is many of their lipids actually got better on a ketogenic diet. Yep. Now, it wasn't just the diet, but first off, it was clean keto. So we're teaching people to eat clean, healthy fats and vegetables. And so that right there is a shift if you're eating, out a lot and a lot of processed foods. But there's other factors with the diet and the lipids, because it's another inflammatory state. But it's, if we get people to not only change their diet, but change their exercise, which we can talk about, which was a facet of all our studies, change their sleep, making sure they're getting good sleep, restorative sleep, so the brain can regenerate, making sure they're doing something for stress reduction. All of those factors. I just see many times their lipids come down, down, down. I'm also often doing targeted things with supplements to facilitate that. But I had one patient in my recent trial, and he was on a statin medication for his lipids, and he didn't want to take it. He'd read some of the stuff, but statins can be a factor with cognitive decline, and he didn't want to take it. And I said, well, I have to advise you that
based on your numbers, the standard of care would be to take the statin.
Yeah.
But if you insist on staying off of it, we'll follow you and we'll recheck your advanced lipids in a couple months and see what happened. Well, his lipids kept getting better and better off of the statin,
Yeah.
probably, 6 months into it. I don't think anybody would have put him on a statin.
Right.
So,
Right.
so I don't think it's an absolute contraindication to saying, oh, you already have high lipids and you have ApoE4 genes. And the ApoE4 gene, as I know you're familiar, Eddie, but not everybody is. Sometimes people call it the fat bucket gene.
Yeah.
And when you have the
Yeah.
ApoE4 gene, you tend to store your fats as lipids in your blood and then fat deposition in your body. So it is more of a fat storage gene.
Yeah.
But again, I have had many people with ApoE4 eating a ketogenic diet whose lipids are getting better. I'm not going to say the ketogenic diet makes their lipids better. I have had some people, whether they're E4 or not, have the lipids go up where we've had to, say, okay, well, you need to get rid of more saturated fats and, maybe cut out the coconut and stick with the olive oil and certainly, less, red meat and things like that. But it's definitely not a contraindication, and it's so worth trying.
Yes.
If you're one of these people whose brain lights up with that.
Yes. Yes. Yeah, definitely. It's my dad has benefited greatly from that switch, and yeah, it's different, but now the ketogenic diet, I think for like the last decade has become more and more ubiquitous. More and more people are comfortable with it, and different ways. There's fasting, there's the ketogenic, a classical ketogenic diet. There's KetoFlex 12-3. There's a lot of different options for people. It's excellent. Exercise, yes.
Well, before we leave the fasting, we do also ask our patients.
That's right.
To practice time-restricted feeding. So we ask them to restrict their calories between 8 and 12 hours of the day. And the thinking on that is if you're eating before bed, then you're busy with digestion and you're not going to have this restorative sleep. And a lot of people that track their heart rate variability on their Oura Ring and their Garmin Viva smartwatches, can notice that eating before bed affects the quality of their sleep. And again, that's not for everyone. I can tell you, I'm somebody with low blood sugar. Yeah. And if I don't eat shortly before bed, my blood sugar gets dangerously low. I've done the CGM, continuous glucose monitors, and, it's, some people are an exception, and obviously we're going to treat people and not just protocols. But for most people, it is better if they don't eat a certain number of hours before bed. And what I've seen in my trials is people start out with 12 hours. And then, as they get into ketosis, if you're eating the proper amount of fats, it's much more, you have much more satiety, you feel more full, you're more steady, you don't have these ups and downs of your blood sugar from eating carbs. And so I'll see people get better and better and often just have their calories in an 8-hour time window after a few months, just kind of naturally without having to think about it. A lot of times people are dropping down to 2 meals a day kind of thing.
Yeah. Yeah.
So yeah, with the different data on fasting and longevity and, decreasing inflammation and everything else, it's a pretty easy thing for people to incorporate.
Yeah. Yeah, absolutely. Yeah, and it just intuitively just seems like it's more aligned with our ancestral, centuries of ancestral living. I don't think we were grazing all the time on high carbohydrate, high processed foods.
There was a lot of feast or famine, right?
That's it. So metabolic flexibility, as Dr. Bredesen would say.
Yeah.
You mentioned exercise, which really complements that really well. What exercise did you guys use for the trial?
Right. Well, another multimodal kind of thing, even with exercise, we asked our patients to ideally try to exercise every day. Our protocol was 6 days a week. And, I tell people, you need to and exercise 7 days a week, because life is going to intervene. Something happens one day, you're not going to do it, and maybe something else is going to happen, and there's just life. So if you plan to exercise 5 days a week and life comes in, you're down to 4 days a week or 3 days a week. So it's just encouraging people to start moving every day.
Yes.
Now, we ask them to do a combination of strength training, aerobics, stretching, and balance training, and high intensity interval training. So, kind of different things on different days. The high intensity interval training, or HIIT for short, is now a very well validated exercise method for certainly improving all your metabolic factors. It can lower lipids and blood sugar and inflammation pretty dramatically, and you only have to do it like twice a week, two, or occasionally people do it 3 times a week, and it's only for a few minutes or 10 minutes max. But I have people start with 30 seconds, and basically you're warming up, doing an exercise, and then you start to push. Say if you're on an exercise cycle, you're gonna pedal as hard as you possibly can, like just to the edge of where you feel like you're going to throw up, but for 15 seconds, and then, try to get to 30 seconds. And, different people in different ages are going to get different levels. There's some fascinating work that's been done with they call it the Norwegian 4x4. And in that study, they followed people for 2 years. I believe they started in their mid-40s. They were in their 40s. And looking at their heart disease risk and issues. And in the 4x4, it's very intense. And, people in their 70s are not going to be able to get up to this level. But in that age group, they had them work up to 4 minutes of HIIT 4 times in a row. So you do it, then ease off for 2 minutes, and then do 4 minutes. And it took them at least 6 months to get up to that level. So nobody started at that level. That's very high level HIIT, but they found that they reverse aged their hearts by 20 years.
Wow.
And so, because typically, we're already taught that dementia isn't reversible. Once you have it, you're going down. And, and then we're also taught that about heart disease. Like once you have it, you're not getting rid of it. And that's not true either.
Yeah.
There are, many things that you can do to reverse, the buildup and the damage that's been there. But certainly the HIIT is one of them. So we like our patients to try to, get up to 1, or, some of the stronger ones can get up to 2 minutes, a couple of cycles. But in our study, we have the dream team of support for our patients. So each patient had an exercise coach, a nutritionist, and a health coach. And, that's maybe not accessible for everyone, but, if people can invest with having some support and coaching in the beginning, you don't need to do this forever, but just to help you get going and do everything right. It's a huge boon for people. And, my hope is with our next study that we'll have enough data that some of the bigger medical systems could take notice, because I feel like if we could incorporate what we do into, Kaiser and the VA and big health systems, I think there's ways to have economy of scale where things be offered for things like, let's get everybody in the, group classes for this kind of exercise and nutrition, with a focus on helping them get going, so that we make it more affordable and accessible for people. I mean, that is a difficult thing, but so my exercise coach in both studies took patients that had never exercised a day in their life. Like some of them just were not exercisers, and turned them into really excellent exercisers and loving their exercise. So, that's not an easy thing to do at an older age with bad knees and a bad back and this and that. But, of course, getting the right exercises and helping to strengthen those things, people had so many resolution of different joint problems that they came in with. I have one guy in my study that he was going to have 2 knee replacements and a hip replacement. He said, I just couldn't get up and down the stairs. It was like one at a time, and it was so painful.
Yeah.
That guy's totally fine today.
Wow.
His joints are fine. He has no pain. I mean, he doesn't, as a side effect of the study, he doesn't need to get 3 joint replacements.
There you go. There you go.
Pretty exciting stuff. So that the exercise, I mean, it's always, we had a board question on my functional medicine boards, and they have all the multiple guest questions, and they kind of, the upshot was you had to decide which was more important, diet or exercise. And I knew the answer they wanted was diet, but I would put those right on par with each other. You got to feed your body the right fuel, not to age it quickly and destructively, but I think exercise is what helps people to go into older age.
Yes.
Feeling strong, in control of their body. Not to mention, of course, one of the big reasons that we do it is also for the blood flow.
Yes.
I mean, that's, the blood flow to the brain and to the heart. And, those are the highest utilizers of oxygen, and exercising can increase your VO2 max and how easily you extract the oxygen, and, help the blood to just flow better, as reducing inflammation in the blood vessels. So yeah, the exercise, some few people have trouble in the beginning, and they don't want to do it, and they need a little more hand holding, and then they turn out to be stars with their exercise programs. So sometimes it does take extra support, and particularly my exercise coach, he's a very high level coach. He was a kinesiologist with the San Diego Padres, so he had worked with athletes, high level athletes, but he now specializes in working with older people. So he knows, how to assess and help them work around, the infirmities of age, and then come out better. So yeah, I think it's a beautiful thing of this work, to turn people and just to get in control of their bodies. It's
excellent. It's excellent. Yeah, it's I mean, what other clinical trial? I don't know of any other clinical trial, and I've scoured through PubMed and read through as much as I can, but I don't know of any other clinical trial where the side effects are people literally transforming themselves, physically, mentally. It really seems like at the end of the process of these trials, people don't just get better a little bit. It just seems to be a total transformation. I mean, you'd think this would be on the front page of every newspaper, on every talk show. It's amazing.
And I mean, I think it is so exciting, but I'd like to maybe add some caveats with that. In our trials, we are doing full court press, right? We have 9 months only to move the needle. I mean, it would be nice, but it's expensive. And, we have a fantastic donor that's funded both of our studies. But what a gift and a blessing, and, a gift that she's giving to all of humanity by doing this. But we do kind of work fast and furious. Patients have to move quickly. We are moving quickly as the clinicians. But we're testing everything and covering everything that we know to be a factor. And when all of that comes together, finding all the causes and helping people to change their diet and their exercise and their sleep, we test everybody for sleep apnea. We also look at, how restorative their sleep is, the various factors with that, work on their stress and their stress reduction, because, stress and depression are known risk factors for dementia as well. So we're kind of working on everything. And to me, it's sad, and something I think about a lot, of how best to help, physicians and clinicians understand and know that they do have to test everything and look at everything to figure out what are their treatment targets for this individual.
Yes.
And so, I always say in the beginning, cast a wide net and test everything up front.
Yes.
Some doctors like to test a little, and then we'll test a little more. And then, but you know what? Your brain is degenerating. You're racing the clock. You can't find out, like, a year and a half from now that you missed this infection or you missed this autoimmune disease. Like, you need to know that. Now, you might not be able to treat all of those things right at once, but what I do is I test everything. And then I make a list. I go through all the labs, all the abnormals. What are my treatment targets for that patient?
Yeah.
And it's multiple things. And some
Yep.
people have a list this long, and some people have a list this long,
Yep.
but these are my treatment targets. And I need to figure out how to best address. Some things can be, you're doing one thing that's going to affect multiple things. There's not like a single treatment for each treatment target, but
Absolutely.
I group them into things and then start rolling up my sleeves and working with that. So I think it's been a criticism of Dr. Bredesen and the work that we do sometimes, like, well, it doesn't work. Well, we've tried this, we've taken a bunch of supplements and we changed our diet and we're not better.
Yeah.
To me, the answer is then let's get maybe a second opinion. Let's figure out what is being missed if you're not getting better.
Right.
Because the results are monumental. Like, I mean, in my, patients, like in this current study, I mean, every single one of them is better. And a majority of them are testing totally normal from really low scores.
Yeah.
People have gotten their lives back. And over and over in the little interviews I've been doing, I've heard several in a row say, like, this is the best thing I've ever done in my whole life.
Yeah.
And this, the protocol things that we ask them to do, it's not easy.
Yeah.
It's very time consuming in the beginning. I think people probably are spending 2 hours a day in the beginning, learning to integrate all these things in their lives. But the payoff is huge.
Yeah, huge.
And to see some of the stories that, hopefully I'll be able to write about, later after I get the how-to book written. But, the people like going back to work or, getting promotions or changing their lives that were, not able to do things before. That is just so heartwarming. One of my patients in this study was a nutritionist, and she was still working part-time and caring for her elderly mother with dementia.
Yeah.
And, she had a lot on her shoulders, but she still managed to do the protocol beautifully, even while she was working and, taking care of her mother. And at the end of the study, she said, I'm functioning so well that it's created all this time in my life. Whereas before I was struggling and going in circles. She took on 2 additional volunteer jobs, one with the SPCA and one with hospice. And both of those volunteer jobs required training. So she had to learn new things, but her brain was working perfectly. She learned the new things, and was able to sort of give back, and so, I just want to acknowledge it's not easy in the beginning. And that's why people do need a lot of support, to make these changes and see them through. One of the things that we did in my site is we made a support group for our patients in the study, the ones getting active treatment, and then the ones with delayed treatment. Once they finished and got into the active treatment, then they were able to come into the study. And that was kind of, into the support group. And that was kind of fun because they were able to hear from the people that were already through, even like, this is worth it.
Yes.
You're being asked to make a lot of changes, but this is so worth it. So I think that it's very nice to have a community of people, maybe even at different levels, that can cheer each other on and be a shoulder to say, oh, this is hard, this diet, or I don't like the exercise, or I don't like the brain training, but to see that. And another interesting little story is sort of the need to stay with all of this. The changes that we're asking people to do are lifestyle changes, and we want them to get happy and comfortable. How can they integrate it into their life so that they can, keep walking the walk of this? And so in my current cohort, one of my patients developed AFib. I think he was through the study maybe, and he went to cardiology, and they said, oh, you need to stop all your supplements. I mean, they had to put him on a blood thinner because of the AFib, and you need to just stop all your supplements. They're dangerous and blah, 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 and worthless. And so he stopped the supplements, and he immediately crashed and burned cognitively. He was so much better, and then he got so much worse. And so then he talked to me, and I said, okay, let me research. I've spent, quite a bit of time looking at every single supplement that might interact with blood thinners. Some are obvious, fish oil and, proteolytic enzymes like lumbrokinase, nattokinase. But I looked at every single supplement to make sure, and I said, okay, here's the ones that can interact. Please stop these. Please go back on everything else,
Yeah.
and then again that made a difference for him. Another patient was doing perfectly, so he said, I don't need to take all this. I'm great.
Yeah.
So we stopped everything, and he's kind of a mathematician guy. He told the group, okay, I stopped it, and he said, I got 60% worse. Like in the next month, he quantified it.
Wow.
And said, my wife could see it, I could see it, I'm back on the supplements, kind of thing. So
Yeah.
it's it's and it's not just the supplements, it's the diet, the sleep, the exercise, the stress, the brain. It's just trying to help people understand how can you put this in, because when you have dementia, it's a disease. It is a neurodegenerative disease.
Yes.
And so you can put that to rest, potentially if you get it early enough, as we're seeing, but you can't just go back to doing everything you did before that caused that situation, right? To me, it's a horrible thing that I see with, people with cancer, and maybe they go into remission of their cancer, but then they think they can eat whatever they want and go back to, the fact that might have, contributed to that.
Right.
So,
Right.
so yeah, I think that's another message that, I like people to understand.
Yeah. Yeah.
That, and maybe you could throw out one part of the protocol and still work, but we don't know. We just know it works when we address all of these
We
factors.
address everything. Yeah. Yeah, definitely. No, it's a lot of great points. And yeah, I've heard that criticism from a lot of people, and I totally appreciate it. The way I look at it is these are early days, and um, the ideal that I look towards is one of the things I appreciate is like every one of us that is on the protocol. I mean, look, I've got a recode household. I got a three-generational household. My parents live with us now, right? And we all practice a protocol, my wife and myself on the prevention side, and we've got dad on the protocol for reversal. And um, one of the things I appreciate about this community of participants and people practicing the protocol over the world is this is a shared struggle. There is a sort of self-actualization that's necessary. This is not a passive sort of process. We're all having to learn a lot of different things, implement these things, troubleshoot, test for more. But the way I look at it is, hopefully 5, 10, 15, 20 years. I mean, geez, if standard of care could just make testing homocysteine as part of your routine annual checkup or some of these other labs, then maybe we don't have to address so many things all at once when cognitive decline comes in, or we're preventing
Oh,
it together.
absolutely.
So what you guys are doing, running these guys through the gauntlet there, like Olympic athletes, it's really just opening things up. And as on my side, if we can just increase awareness as much as we can, and we have enough patients demand this from their primaries, from their neurologists, hopefully we can get enough people to change the way that practitioners may even view what you guys do so that there's more training and it becomes more accessible. So hopefully there aren't so many things to address for most people down the road because
Yeah.
so much of it's being caught on. Yeah.
Yeah, exactly. They'll have less treatment targets, right?
Yep.
If we
Yeah.
prevention is obviously where it's at, and
Yeah.
it became increasingly difficult trying to have our Group B patients that we didn't want to do anything, because I do feel like things. I'm optimistic.
Yes.
I do feel like what we're doing is making a difference, and it's creeping into traditional medicine, traditional neurology. Poor Dr. Bredesen's had so much criticism. You're a snake oil salesman. This is for making money and blah, 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 and it doesn't work. And, I mean, I know you've heard all of that, but, but what I see is changing. Like even you mentioned, like our first paper, I think we're at 70, 71 citations. That means other papers have cited our work in their papers, in the academic realm. So that's at least a marker of some uptake. of what we're doing. But one of my patients in Group B, this is an example of some of the difficulties of being in Group B, and also how some of these changes helped him.
Yeah.
He had a doctor who tested his B12, and she said, well, your B12 is in the normal range, but I've read that, even the lower numbers could make a difference with dementia. And so, I spoke to Dr. Bredesen. I said, well, they want to put him on B12, or she put him on B12. And he said, well, some neurologists might do that, so let's let him keep it. So, and his B12 was, I think, normal, like must go down to like 300 up to 1200 or something, but he might have been 400, and I would say most doctors probably wouldn't have treated that, but he had a smart doctor. Yeah. So we let him go on B12. Well, this gentleman's MoCA, he barely made it in the study. He was in the mild Alzheimer's range. Yeah. And he gained 2 points on his MoCA, yeah. But it wasn't just the improvement on the testing. We could see it cognitively. He was quicker, sharper. He was able to gather everything together for the family taxes, with a MoCA of 21, which is still pretty low, but he was a very brilliant man. And so he got better.
Yeah.
And then next thing I knew, she tested him for sleep apnea.
Yeah.
We test all our patients for sleep apnea, even thin women who don't snore, you can still find it. So everybody gets tested, and we test for 3 nights. We do home testing, which has become readily available in most of the sleep labs these days. And, I've always advocated test 3 nights in a row, because sometimes I'll see 2 nights that are fine. Yep. And then 1 night looks pretty dicey. So, it's obvious if you have severe sleep apnea, you're going to see it every night. But when some of the milder cases, you might miss it if you only test 1 night. Yep. So anyway, his doctor had tested him. Well, this gentleman had severe sleep apnea. It was no question. He needed to go on CPAP. And of course, I couldn't ethically withhold that. Yep. I couldn't say, well, you have to wait 6 more months to take this. No, so we put him on CPAP. Well, he gained 2 more points on his MoCA.
Yeah.
So, from those 2 single interventions, he gained 4 points on a MoCA, from 19, up to 23. Like that's a clinically relevant change.
Very.
So, it was, it screwed up my data, but of course, I knew what, was needed for him as an individual, so it's, we hope that after this study that there won't be any more need to randomize some people to not have treatment, because I feel like it's unethical, the more we're seeing how much, people, don't get better or decline without treatment compared to how much better they're getting with treatment. Yep. That, I think we should just use historical controls and say, we know this data, this much decline happens with MCI, this much with Alzheimer's. Like, I don't, it's been a criticism of the lack of a randomized controlled trial of work that we do, but hopefully this will be the last one needed, is what I would like to see.
Yeah. Yeah. Not great. Yeah. You guys touch on a lot of things, the diet, the sleep, the stress reduction, the exercise. And then, there's all these things that we've learned from the cognoscopy. Some viewers know, hormones and checking for toxins. You mentioned chronic infections, and I think this is something that's really relevant, especially today. Viral, bacterial, fungal, parasitic, whatever it may be. What are some of the most common chronic infections that you're finding in patients when you test for them?
Yeah, herpes is the biggest, and the one that we have very clear data with the correlations, especially of herpes simplex 1 to Alzheimer's, but to a lesser degree 2, and also HHV6, which is human herpes virus 6. Those 3 variants of the herpes virus are huge. And there was a fabulous study. There's a few studies, some bigger studies on herpes in the brain, but there was one done in Taiwan, I think it was, and it was with more than 30,000 people. And they showed that if people took a single course of antiviral medication, like typically with herpes, we're treated with valacyclovir or acyclovir, a single course of medication, say for acute herpes, their risk of getting Alzheimer's was dramatically lower. I can't now remember the exact number, but it was a huge impact of lowering your risk of getting dementia by treating your herpes. It's herpes has been part of a standard Alzheimer workup as long as I can remember, 35 years in this field. That we always tested for herpes and we tested for syphilis. But classically, people didn't really treat much for herpes. Yeah. It's pretty ubiquitous. I think 90% of us, or close to 90% of us, have had, the herpes 1, which is the cold sores and, sure, lesions on the lip as children. And so when we have these viruses, they integrate into our bodies and we don't get rid of them, but our immune system keeps a lid on them. Mm-hmm. And stops them from reactivating and causing symptoms. But sometimes in times of stress, in times of illness, or aging in general can cause a decline in immune function. Then viruses can wake up and reactivate and start replicating and start causing symptoms. So, treating the herpes, to me, that's kind of easy, low-hanging fruit. In my world, the thinking is when looking at the viral titers, they give you a number of, how active that virus is. And if it's 4 or more times higher than the cutoff of normal, we tend to consider that reactivated and worthy of some treatment. Mm. So say the cutoff for herpes is 1, and then you have a level of 5, then we would say, well, we should treat that. And now how long and aggressively to treat it is an unknown. We don't really have any clear data on that. It generally, as I told you, you don't really eradicate the viruses, but you try to knock down the levels, and that happens slowly. Yeah. So with the treating people with the antiviral medication, the only thing I could find was Stanford had done a study using valganciclovir, which is another antiviral. It's got more side effects, so I don't use that one, but it's a more aggressive one. They were using it for chronic fatigue, and they treated people for 18 months. And then just before COVID, there was a study coming out of Columbia where they were treating Alzheimer's monotherapy, so only one therapy with valacyclovir, also for 18 months. And I remember writing to the PI on that study and asking, how did you come up with 18 months? And I never heard back from them. And I should probably try to revisit that because, I don't know, both of those studies picked 18 months as their, length of treatment. And so we just don't know. I'll treat people for, 9 to 12 months and follow the levels. And if I see them, coming down, to good levels, then I might stop the medication, or I might just put people on a little tiny dose. The medications are approved for chronic use for herpes prophylaxis for people who have recurrent herpes. So, it's been shown to be safe to use long term. Those antivirals can be hard on the kidneys. So they're not a problem if you have normal kidney function, but I always monitor the kidney function when they're on that. And I've never really had a patient develop kidney problems from it. I mean, we're dealing with their general health, and usually I see kidney function getting better with all that we do and not worse. But that's the one caveat. So herpes is a big one. Epstein-Barr virus is another big one. And, people generally they're symptomatic when that reactivates because they have chronic fatigue. Yeah. That's another thing that we tend to work with some different herbal protocols to help lower that, and other things for immune support. The big ones that are, way too often missed are the tick-borne infections. So Lyme disease, Babesia, Bartonella, Ehrlichia, Rocky Mountain spotted fever. We tested for all of those in our study. Yeah. And the testing is difficult and sometimes expensive. Yeah. The traditional Lyme testing, people will say, well, I tested it, Quest or LabCorp, and I was negative. Well, that doesn't tell me anything. The testing done in the traditional labs like that is only tending to look at one strain, like of Lyme. They're only looking at one strain, and there are different strains for Europe, Asia, East Coast, West Coast. There's a lot of variability. So you need a more sensitive testing that will look at different strains.
Yes.
And the first step is to look at a Western blot that they put the sample and they put it on an electrophoretic gel and they run the gel and then they stain different kinds of proteins, and they're called bands because they stain as little bands in the gel. And we kind of look at a pattern. Some of the bands are highly specific to Lyme, and some might be from other viruses and other infections. And what's happened in the traditional testing, they threw out a bunch of the bands because if you had taken a Lyme vaccine, you would have those bands. The Lyme vaccine would activate the reactivity. So they said, well, we can't put this in the test. Well, then you're throwing out the major things that are going to diagnose people that have it. And very few people took that vaccine, and it's no longer available. So that was kind of crazy. So we tend to use, there's, two different companies that I'll use for testing. One of them is iGenix Labs, and it's the I and then Gene, like Gene, and then X. That testing tests all different kinds of strains, and they now do something called an immunoblot that's not just a Western blot. It's more sensitive and more specific, but it's expensive.
Yeah.
If you have Medicare and you have proper indications, like to me, cognitive decline, and is a proper indication to test for something like this that's known to get into the brain and affect the brain, it can be covered on Medicare. But for people that don't have Medicare, that are under 65 or don't have Medicare, it's generally not covered by traditional insurance, and it can be expensive.
Yeah.
So that's a barrier, though they're just starting to get some coverage with a couple of insurance companies. So I hope maybe that will change in the future. But an interesting story about the different strains. So my sister tested with them for Lyme, and her doctor said, this must be wrong because it says you have a European strain and you have an Asian strain, and my sister lives in the DC area. Yeah. And my sister said, excuse me, I'm in career Army, and I've, lived many years in Europe and many years in Asia,
Yeah.
And those were the strains she had. She didn't have any US strains.
Wow.
So, it's, that was pretty telling to me, wanting to use something more sensitive. There's another company that I use called Infectolab, and Infectolab tests whether the T cells, which are a subset of our immune cells, are reacting to specific viruses. Mm-hmm. And so the thinking is, if your T cells are reacting to whatever, virus or Lyme or, spirochete or parasite, then they're going to remain active until 4 to 8 weeks after that infection is cleared. So sometimes that's a way to say, if I'm covered in infections at iGenix Lab and I'm treating them, and then when do I safely stop the treatment? I might test their T cells to say, okay, they've cleared this now, or no, they're still reacting. We need to, go longer with our treatment. So, there's sort of a little bit of art and a little bit of barrier because of the cost factors of those things. But to me, it's essential. If you have cognitive decline, that is something that is worth, funding and finding a way to test, because Lyme is a spirochete. Syphilis is a spirochete. And syphilis, we've long known, since the 1800s, classic was a man got some kind of sexually transmitted disease, and then he got better. And then some years down the road, he went crazy. Yeah. He had, dementia, because the spirochete gets in the brain and loves to live in the brain tissue and wreak havoc. Well, Lyme is a spirochete just like syphilis. Yeah. And there was a really chilling case report a few years ago of a woman who was, she had Lyme, she had the classic rash, they treated her right away, things got better, they thought it was enough treatment, and then she died of dementia, and they did an autopsy and they found live spirochetes in her brain.
Yeah.
So, Lyme is a tricky organism. They call it a stealth organism because it has ways to evade the immune system by going in different forms and making biofilms around it. Wow. But it's just something we cannot and should not be missing. And with that comes some of the other Babesia, Bartonella, those can be transmitted by the ticks. Those two, but all three of those have
well characterized neuropsychiatric manifestations, a lot of psychiatric disability with some of those things, in addition to the brain, the joints, and the blood. I mean, some people are having a lot of decreases in their white count and their lymphocytes from things like babesia that's in the red blood cells. So,
Yep.
and the white cells. So yeah, I think testing all those, there's a bunch of them. I have a list of all of the infections that I test. I have a free ebook on my website that people could request if they're interested. It's maybe 22 pages or something. I kind of put that together because so many people are waiting for me to write a more definitive book about how to do all this that, I'm planning to hibernate the rest of the summer and get finished. But in the ebook, I do have a list of all of the infections that I think are the most important and that I do test for. A lot of them can be tested at Quest and Lab. Of course, some of the other viruses, like we test Epstein-Barr there, and we test herpes there, we test cytomegalovirus, we test toxoplasmosis. So, I have a list like 2 pages long of infections that I found good evidence that affect the brain and the cognitive function, but, trying to parse it down to what are the ones that are most likely, and that we need to test for. So we do test for a lot of infections that can affect the brain. I mentioned COVID already, and that's another one. Sometimes if I feel like people might still be reacting and having long COVID, then the question with long COVID is it the immune fallout from the infection that it activated your immune system, and then your immune system is still in overdrive and causing problems? Or is there still active infection? Are you still reacting to the spike protein? And so that T cell testing at InfectoLab, I can test COVID there to see, is that person still reacting and perhaps needing some more direct, antiviral COVID support or not? So infections, I do feel like people are missing that. They don't necessarily have the knowledge base to test it, but if doctors could at least look at the list and test it, even if they're not familiar with how best to treat it, then they could say, this is a treatment target, and I better refer to someone who has experience with treating that.
Yeah, absolutely. Well, such a wealth of knowledge, and you've done so much in the trenches. I wish every neurologist, every doctor had this skill and this training already. And I know we're getting there. But just for the sake and honoring your time, we've touched on some really great things. The infections are important. We know, mold is important. Oral health is important. It's a big factor.
Oh yeah, the oral health.
Yeah.
I had one patient fire me over that a few years ago,
Really?
and I gave them so many studies showing the correlation, but the person I'd kept her stable for many years she came with a moderate dementia, so that was already a pretty good coup, and suddenly she declined. And I said, let's retest everything. Something's changed. And I said, have we done a cone beam CAT scan, to see what's happening with your dental health? And they said, yeah, we just did one, and she needs to have 2 root canals. She's got infections. That's a whole other long story about the root canals and the infections, and much rather have the tooth pulled than leave. And the infections in the root canals go beyond the roots. They go into little microtubules.
Yeah.
So they do the root canal, so you no longer feel pain, but that infection can still be triggering the immune system. It's right there getting into your brain. So, I said, I think we should pull the teeth. Well, the woman had treatment for osteoporosis, which can cause osteonecrosis of the jaw. So 2 different dental surgeons said, no, we can't pull the teeth. But the 2 dental surgeons told the husband that I was a quack for saying that the infections could affect her brain.
Oh boy.
And even at that time, I had, I sent him a half dozen really nice studies showing that. But now we know, even if you have gum disease, your risk of getting Alzheimer's is like 40% higher or something.
Oh yeah.
Insane. So this is something that people of all ages should be addressing their dental health. I think we should say a word about the hormones.
Yes.
Before we, leave this, because I do feel like the big things people are missing. People have dialed into the metabolic health and the lipids and the blood sugar and the inflammation and the gut microbiome even, and
people are doing pretty well with that, but I feel like people are missing the infections. They're missing the impact of the toxins, the chemical toxins, as well as the mycotoxins, and then the hormones. And the hormones, that should be low hanging fruit. That should be easy to dial in. But unfortunately, a lot of physicians are reluctant to give older people hormones. But there was a good study done at Stanford, now getting more years, 8 years ago, maybe. And they took women at high risk for Alzheimer's based on their genetics and their family history that had been on hormone replacement, and they randomized them either to stop the hormones or stay on them, and they followed them for 2 years, and they looked at cognitive testing, and they looked at their head scans, and they found that at the end of 2 years, 100% of the women who stopped their hormones had decline in their testing and their head scans. And it didn't matter whether they were on bioidentical hormones or the old synthetic hormones that we do not recommend people take. When they stopped those hormones, they declined. And that's a pretty compelling study, to show what happens. But we see, so much decline that is related to the menopause transition in women. And then in men, it's called andropause, when they lose their testosterone. In women, it happens more abruptly. It's a 10-year period and bang, they're gone. Yeah. Men, it's goes more slowly, but it does go. That testosterone is declining with age. That's well known. And so, somebody at 60 may have a low testosterone, but somebody else may be 70 until they have a low testosterone. There's variety. You have to test it to know what the levels are. And then for men, the testosterone turns into estrogen, and it's the estrogen that's protecting their brain and their heart and their bones.
Wow.
And many other things. So we have hormone receptors in our brain. Both men and women have estrogen receptors, progesterone receptors, testosterone receptors, pregnenolone, DHEA, all these hormones. Our brain needs those to function. That's why it has all those receptors in the brain. And so, our thinking is that we want to give the brain the hormone levels that it needs to support it. We don't want to give enough hormones to, make you like a 25-year-old man or a 25-year-old woman when you're 65 or 75. Just, to just give enough. There's a sweet spot, right? How much is enough is not known precisely, but especially with women, it's so obvious for some women as soon as you get their estrogen level up, their word finding difficulty gets better. I remember that myself too. I mean, part of my, dementia that I had, which was, way more than just word finding difficulty. I couldn't even decode what was being said. I developed auditory processing and I couldn't understand what was being said. But I remember the word finding difficulty. And I went to my doctor back then and said, I'm having word finding problems. I can't think of what I want to say. And sometimes I even say the wrong word. Like I meant to say, open the door, please. And I would say, open the window, things like that. That was pretty shocking. And my doctor said, welcome to perimenopause. She goes, this is a sign of perimenopause. And we see this. And so I felt good for about 5 minutes. I'm like, oh, okay, this is perimenopause. I was, probably in my late 40s, close to 50. And then I went home and I thought about it. And I said, well, wait a minute. 50% of women are going to get dementia. Right, 50%. And I wonder if the people that are having this cognitive problems might be related. Well, bingo, of course it's related. So getting people back on all those hormones is a huge factor. And we're kind of going, against what has been taught to gynecologists and doctors historically. The old studies and all of the big studies we have are using synthetic hormones. So, the Premarin and Provera, and they're not bioidentical. They're not in the same form. The Premarin came from pregnant horses' urine. And, those are not the same hormones. But we know that taking oral estrogen creates this hugely inflammatory state. It goes through the liver, creates all these metabolites that are very inflammatory. It raises your risk of stroke, of heart attack, and so they're horrible things to take, and they're still on the market. I mean, I don't know why they're still on the market, but if I have a woman that comes to me on oral estrogen, I say, you know what, I cannot treat you if you want to stay on this. The risk is just too high. Yeah. but taking the estrogen through the skin, transdermal, either the patches or creams, it doesn't go through the liver and doesn't create all those metabolites. And so, also the doctors say, well, we can't give hormones if you've been off of it for 10 years because your risk of heart attack and stroke is so high.
Yeah.
But your risk of heart attack and stroke is high because you haven't been on hormones. So the hormones are protective of the heart and the blood vessels. Great papers on that. I have a friend that's had several papers published on that, one in the British Medical Journal, the cardiovascular benefits of estrogen. But women have a lot less heart disease than men until menopause.
Yeah.
And they show as soon as you hit menopause, you fall off that heart protection curve and you start approaching the level of risk of men. So the estrogen has been protective. So if you haven't had your estrogen for 10 years, you've developed, all kinds of more problems with your blood vessels, your lipids, your risk of heart attack, your heart stroke, et cetera. So I'm trying to get some of my, well-known GYN friends to, and they're doing more talks and putting together this. And I, hope one of them will write a book about it. I call it geriatric HRT. So
Yeah.
HRT is hormone replacement therapy. And I said, we need to normalize the conversation around geriatric HRT.
Yes.
And one of my friends who teaches all over the world on hormones and the benefits for the brain and the heart says, how can this hormone that we've had our entire life suddenly become dangerous for us?
Right.
Like it doesn't, right? So, you might see more heart attacks and strokes, but those people are already at risk. So, but I feel like as you were talking about the prevention is we can also convince people to start supporting those hormones in the menopause transition or for men, when they need it. Then we won't even ever fall off the curve and, the bones won't crumble and the brain won't crumble. So that the testosterone for men, sometimes I see men in their 30s and 40s with low testosterone because they have Lyme disease or they have mold illness, things that are affecting their brain.
Yep.
And so when the brain is inflamed, it's not going to make those hormones.
Yep.
And in younger men like that, if you treat the causes, their hormones can come back. But after a certain age for men and women, the sex organs have given up. They're not going to be making the hormones. So then you're looking at long-term hormone replacement. But again, another, huge benefit. And testosterone is a brilliant antidepressant for some people. It has dopamine-like effects. And dopamine is when people have ADHD, they have low dopamine. And that's one of the things in stimulants. But it helps their focus and their motivation. It helps apathy. So it's got great benefits for men and women. And for women, it's little tiny doses, so you have to get it compounded. There's not commercially available testosterone in the doses that women would need. But supporting all those hormones and then right on down to the pregnenolone and the DHEA. Pregnenolone and DHEA are hormones, but you can buy a supplement for those.
Yes.
If you have to take testosterone, it's not only a prescription, but it's a controlled substance because it can be abused by bodybuilders. So, there's quite a spectrum. But just like I talk about treating all the causes, I test all the hormones and get all those hormones in balance. And that includes the thyroid hormones, which is, also part of that whole HPA and then thyroid axis. But so I feel like the hormones are a huge thing, and trying to, have enough, gynecologists and primary care physicians that are comfortable with prescribing them for older women, because unfortunately they just weren't taught to do that in their training.
Sure.
But I see that conversation changing because as they get older, they want to go on the hormones. And a really wonderful study just came out earlier this year looking at the hormone levels, the estrogen levels. And, this was something that they said we haven't had much data on, and we're kind of going clinically on things. But in our first study, we used a target estrogen level of 50 to 80. In this study, based on everything we've all learned and seen, we used a target level of 80 to 120 for the estrogen. And a study just came out that really validated the need for these levels. It said that
50% of women on hormones are underdosed. They're not getting enough of them. But doctors just give a one size fits all, and then they don't monitor the levels and optimize those. But they showed that a level of around 50 or 60 could stop the hot flashes for, at least 50% of the people, and might stop the bone loss. But if you actually had active bone loss, you needed levels of like 80 to 120 or even higher to reverse the osteoporosis, which is a huge risk factor for death in women. If you have osteoporosis and you have a fall and you fracture your hip, your risk of mortality in the next year is sky high. So anyway, that study to me was very exciting to give us some validation on the levels that at least are trophic for the hot flashes and the osteoporosis, and we can then try to extrapolate for the brain and the heart from that. So anyway, it was a big, nicely done study. So I'm happy to have that data substantiating that following the levels and optimizing that is important, since that's what we do.
That's excellent. That's excellent. Well, we should all be so lucky if we had a great doctor in our corner like yourself that leaves no stone unturned. So yeah, this is great. I mean, so much to cover. I feel like we have to have you on at some point later on, especially after that study is over. But
yeah, I'll be thrilled to come back and show you the data on that.
Oh, that'd be great. That'd be great. I'm excited. I think all of us are excited for this one. Now, one of the last questions here. What's one step that every listener would take after listening to this interview, that one step to help them improve their cognitive and brain health?
Again, it's probably not just one step, right?
Yeah.
But I mean, I think it's the basics of general health, right? Like eat right, try to make your diet as clean as possible, exercise. Again, a huge part of it's shown that, muscle strength is one of the biggest predictors of longevity. So, not just walking, but, do some weight training and try to incorporate a little HIIT depending on your fitness level. And then sleep, critical. That's when our brain detoxifies. We need to get into deep sleep to have that good detoxification of all those accumulated chemicals every day. And you need to then work on your stress because, that's when we heal, when we're in parasympathetic mode. But if we're in the fight or flight and high stress mode all the time, there's no opportunity for your body to heal or restore or regenerate. So, I mean, I think that's just basic health, right? Eat, sleep, exercise, stress, those kind of things. And then you can dig deeper into the other things as needed. One thing that I would mention too is midlife hearing loss is one of the most reversible causes of Alzheimer's. When you lose your hearing, you're losing those inputs into your brain, and same with your vision. People are more, in tune with checking their vision, keeping their vision corrected, but all of our sensory inputs, and including the smell, because we've seen all the problems with COVID, and you can do things to, sniff essential oils and stimulate your smell and get it to come back if you've lost it. But the hearing loss is something that people just put off a long time. So I advocate getting a hearing test by 50, get a baseline. If you're great, then you probably can wait 5 more years or something if you're not. But if you're having early hearing loss, getting hearing aids sooner rather than later is a better thing to do. So, I think there's beyond some of the obvious things, that's one. And of course, you mentioned the oral health, keep up with your oral health. And there's actually some cool tests you can do now. They run about $90-$100, but you give saliva, you swish some saline in your mouth, spit in a tube, and there's a couple of them they'll give you the major microorganisms, what levels, and they know which ones correlate with dementia, which ones correlate with heart disease, which ones correlate with arthritis.
Nice.
But you can get a printout and then work on improving your oral hygiene and oral health to shift that. So I think probably the hearing and the dental on top of the basics there.
Beautiful, beautiful.
And
Well,
and then I just think also, I mean, there's so many things that you think of, but
yeah,
especially with aging, just keeping your sense of community and
yes,
connection to people
yeah,
is vitally important. They say that, retirement is a risk factor for dementia. And it is if you retire and you go home and you watch TV and you're not interacting with people, not stimulating your
yeah,
brain. I mean, there's just, so many things that happen at, the heart level and the emotional level with our connections with other people. So I think staying connected with community is good. And
yeah.
I think we're going to end our interview because my big dog just came home from a camping trip and he's going
That's
to
good. That's good.
yeah.
That's a good stopping point. But hey, where can people find you and your resources, Dr. Toups?
They can just search my website, dementiademystified.com, and that has a link right there on the top for the free ebook that I have if people would like to download that.
Great,
And
great.
then I have a YouTube channel. If you just put my name, Cat Toups MD.
Perfect.
I need to update it with some more recent things, but I do have some educational talks and information on there.
Beautiful, beautiful. Well, look, Dr. Toups, we'll link all that in the description below for everyone to access that. And thank you so much for your time. Thank you for making this time. Thank you for everything you've been doing, everything you're doing. We're very grateful for this cutting edge work. It's really life-saving information. So thank you, and looking forward to connecting with you down the road.
It's my pleasure. I just really, want to leave you with my favorite slogan, which is dementia is not a death sentence.
Yes.
So just, hopefully we can continue to empower people to know that they don't have to feel hopeless with this. They just need to take action.
Yes. Yes. Thank you. All
Well,
right.
thank
Thanks,
you.
Dr.
Thank you
Toups.
for helping us spread the word. Appreciate it.